Okay. This patient has tibial fracture complicated by non-union. A tibial fracture complicated by non-union defined as failure of the fracture to achieve radiographic or clinical evidence of non-union within an adequate time frame, 6 months of long bone fracture. Risk, fact- Risk factor for non-union include impaired blood flow, smoking, arterial atherosclerosis, certain medication, systemic glucocorticoid, metabolic disorder, diabetes, hypothyroidism, and infection, osteomyelitis. Acute osteomyelitis typically presents with local pain, erythema, fever over a few days or weeks. However, if the bony infection is not complicated, if the bony infection is not complicated or eradicated, it can be chronic indolent infection, chronic osteomyelitis with necrosis and fragmentation. With necrosis and fragmentation of the bone, chronic osteomyelitis is a common complication of high velocity tibial fracture because the bony fragment are often exposed because the bony fragments are often exposed and the blood supply may be disrupted by the trauma. A sinus tract with a persistently draining wound, as in this patient, strongly suggests chronic osteomyelitis. Intermittent pain and swelling may occur. However, fever and leukocytosis are usually less prominent. The diagnosis is suggested by the patient's X-ray, which show fragmentation of the bone and a ragged, irregular fracture line. ESR, CRP are often elevated. Open bone biopsy is preferred over percutaneous aspiration for microbiologic sampling. Culture of sinus tract generally has poor sensitivity and specificity. Surgical debridement of the infected wound and necrotic bone is required for definitive management. Okay, it's osteochondroma. The adolescent has examination and X-ray finding consistent with osteochondroma. The common benign bone tumor osteochondroma consists of osseous spur with a cartilaginous cap. Osseous spur with a cartilaginous cap usually presents sporadically as an isolated lesion. The presence of multiple lesions, as in this patient, typically indicates hereditary condition. Osteochondroma develop in the long bone metaphysis. Osteochondroma develops as a long bone metaphysis of the skeletally immature patient. They are detected examination fixed hard nodule near joints and are generally non-tender, although they may cause pain due to compression of local neurovascular structure after trauma as seen in this patient. X-ray demonstrating well bony outgrowth with a sessile pedunculated base confirmed the diagnosis. The lesion projects away from the epiphysis and have continuity with the cortices and medulla of the adjacent bone. Because osteochondroma stop growing once patients reach skeletal maturity, when fascial closure is complete, and have a very low risk of complication. Pathologic fracture, malignant transformation, they are typically managed with observation alone. Okay. Is it grip myotonia, like myotonic dystrophy, genetic testing? Okay, this patient muscle pain, weakness and delayed relaxation concerning for myotonic dystrophy, delayed relaxation concerning for myotonic dystrophy. Uh, okay, myotonic dystrophy is an autosomal dominant disorder in which trinucleated repeat DMPK gene is transcribed into untranslatable mRNA that is toxic to cellular function. Longer repeat expansion genetically correlates with an earlier onset of more severe disease anticipation. Presentation clinically involves muscle weakness, pain, atrophy, particularly in the distal hands and feet, and facial long and narrow face, sagging jaw, hollow cheeks, muscles. Foot drop. Foot drop may result in frequent falls and unsteady gait myotonia. Unsteady gait myotonia is a characteristic feature that can be elicited by percussion of the thinner eminence. Percussion of the thinner eminence, which results in thumb abduction, followed by delayed relaxation, percussion myotonia, or by sustained muscle contraction after the release of handshake, grip myotonia. Involvement of cardiac muscle can result in cardiomyopathy or arrhythmia and sudden cardiac sorry, sudden cardiac death mm, in patients with further raises suspicion for an undiagnosed metabolic dystrophy. Non-muscular manifestation can include hypogonadism with decreased libido, non-muscular manifestation hypogonadism with decreased libido, and testicular atrophy as seen in this patient. The diagnosis is based on clinical findings and family history, and DMPK gene testing is confirmatory. Management include physiotherapy for weakness and testosterone replacement for symptomatic hypogonadism is generally supported. Okay. This patient likely has a calcaneal stress fracture, which is caused by repetitive microtrauma, in high impact activities running. Calcaneal stress fracture occurs. Calcaneal stress fracture occurs most commonly in young men and young men and obese individual. Patients typically have heel pain that is worse with ambulation, especially during the first step of the morning or after rest. Usually during the first step of the morning or after rest. Examination show tenderness. Medial examination showed tenderness on the medial on lateral squeezing of the calcaneus squeeze test. Calcaneus squeeze test. The diagnosis can be confirmed by imaging. X-ray may show a zone of sclerosis but is frequently negative in early stage. MRI is more sensitive. MRI is more sensitive mm, for early stress fracture and would be most appropriate for this patient within 2 weeks of symptom. Treatment includes temporary avoidance of weight-bearing activities, use of crutches, heel pads that dissipate impact during ambulation and are also recommended. Calcaneal stress fracture usually heals well with conservative management. Okay. What is your diagnosis? Lupus does make sense. Why? Yes, she has joint pain, she has oral ulcer, she has thrombocytopenia, and lupus can cause lupus cerebritis, vasculitis. Okay, this patient with a generalized tonic-clonic seizure, this patient with a generalized tonic-clonic seizure has evidence of multi-joint arthritis, facial rash, oral ulcer, mild pancytopenia, and suggestive of a diagnosis of SLE. SLE is a multi-system inflammatory disorder that can affect at that can affect almost any organ. CNS manifestation commonly include vasculitis, thrombotic or thromboembolic disease, antiphospholipid antibody syndrome, seizures, transverse myelitis. Lumbar puncture is useful. Lumbar puncture is useful when CNS involvement of SLE is suspected. CSF fluid may be normal or reflect mild inflammation. Slight elevation in the CSF leukocytes or lymphocytosis, as in this patient. Although CSF pleocytosis can be seen with CNS infection meningitis, given the subacute multisystem nature of these patient's symptoms, an inflammatory condition such as SLE is more likely than an infectious agent. The negative gram stain results with only mild leukocyte elevation and make bacterial meningitis less likely. Okay. If there is decreased active and passive range of movement, decrease active and passive range of movement, go for frozen shoulder or adhesive capsulitis. Okay. This patient has shoulder. Okay, this patient has shoulder pain, shoulder pain with decreased passive and active range of motion, shoulder pain with decreased active and passive range of movement, finding consistent with adhesive capsulitis, termed as frozen shoulder. Adhesive capsulitis is characterized by loss of normal distensibility, loss of normal distensibility of the joint, glenohumeral joint capsule due to chronic inflammation, fibrosis, and contracture. It is most common in middle-aged and older individuals, and the risk increases in patients with diabetes mellitus, thyroid disorder, or chronic mobility. It is also common in patients with rotator cuff tendinopathy or shoulder trauma, proximal humerus fracture. Patients with adhesive capsulitis typically report gradual onset shoulder stiffness that limits the ability to flex, abduct, or rotate the humerus. Accompanying pain is often severe at the onset. Accompanying pain is often severe at the onset, but typically improve over time, weeks to months. The diagnosis is confirmed by demonstrating a reduction in both active and passive range of motion in multiple planes. X-ray findings in this patient are usually normal, and imaging is used primarily to rule out other causes of pain. Okay. Okay, is it vertebral compression fracture? Okay. This patient has an acute vertebral compression fracture VCF, typically presents with back pain, decreased spinal mobility, decreased spinal mobility after bending, coughing, sneezing, or lifting, even some weight. The pain typically increases with standing, walking, or lying on the back. Gradual onset of vertebral compression fracture can be asymptomatic and noted incidentally on imaging performed for another reason. Multiple compressions are often seen. Vertebral compression fracture with a prevalence of 25% in women aged more than 50. It is usually due to osteoporosis, which is likely in women at age 75 with a history of systemic glucocorticoid use. Additional risk factors include other metabolic bone disorder, hyperparathyroidism, osteomalacia, infection, osteomyelitis, and malignant bone metastasis. VCF can occur in patients with normal bone density following severe trauma, fall from a height. Examination may show localized midline tenderness. Examination show localized midline tenderness with a percussion and with percussion and palpation. Neurologic deficits are usually absent. The patient's absent the patient's absent the patient's absent ankle reflexes are less likely due to normal aging and not clinically significant. Large or repetitive VCF may be visible as kyphosis and loss of height. The diagnosis is confirmed on X-ray, almost which most commonly shows anterior wedge deformity. Okay. Needle shaped crystals. What is your diagnosis? Okay. This patient has acute gouty arthritis. Gout usually presents with isolated attacks of intensely painful monoarthritis with nearly 80% with nearly 80% occurring in the metatarsophalangeal joints and knees. Patients also develop localized erythema and swelling, which is often mistaken for cellulitis. Synovitis in acute gout will show an inflammatory pattern with a cloudy appearance, elevated leukocyte count, 2000 to 1 lakh cells per milliliter cube, and neutrophilic predominance under polarized microscopy. The synovial fluid will show monosodium urate monohydrate crystal, needle shape, monohydrate crystal, needle shape, negatively bifringent, appear yellow when lying parallel to the polarizing axis, and blue when perpendicular. Patients generally response. Sorry. Okay. In gout, patient generally responds to indomethacin, colchicine, corticosteroid, and long-term allopurinol. Okay. Next, I am reading in a monotonous manner. Okay. This patient, this patient with diabetic peripheral neuropathy, decreased sensation below the knees. This patient has diabetic peripheral neuropathy, decreased sensation below the knees, and developed diffuse unilateral foot edema 3 months ago, and now has collapsed midfoot arch. Now had collapsed midfoot arch, raising suspicion of neuropathic Charcot orthopathy. Neuropathic Charcot orthopathy. Neuropathic orthopathy involves repetitive bone and tissue trauma, which results in impaired sensation and joint proprioception. Impairment of these medication comprises the weight-bearing adjustment that normally prevent mechanically induced wear and tear during the early stage of acute neuropathic orthopathy. Significant inflammatory changes, erythema, edema are predominant with minimal osseous changes, and minimal osseous changes visible on X-ray. As the disease progresses over month, inflammation subsides as mechanical bone and joint destruction become prominent. Chronic neuropathic arthropathy. Chronic neuropathic arthropathy can be diagnosed based on clinical and X-ray finding with no need for additional diagnostic testing. The patient's X-ray reveals osseous reabsorption. Patient's X-ray reveals osseous resorption, architectural foot disorganization, mid-foot arch collapse, and the anatomical alignment intertarsal between the intertarsal and tarsometatarsal articulation changes commonly found in early neuropathic Charcot arthropathy. Okay. Okay. This patient with back pain radiating to the thighs. Back pain radiating to the thighs has symptoms of lumbar spinal stenosis. Spinal stenosis is caused by narrowing of the spinal cord leading to compression of the one or more spinal nerve roots. It is primarily seen in degenerative arthritis with osteophyte formation affecting the facet joint. However, other factors may contribute, including hypertrophy of the ligamentum flavum, bulging of the intervertebral disc, and spondylolisthesis, displacement of one vertebral body relative to another. Most patients are over 60. The symptoms of spinal stenosis are posture dependent. Extension of the lumbar spine, standing, walking upright, further narrow the spinal canal and worsens the symptoms, whereas lumbar flexion, walking uphill, leaning on a cane, relieves the pain. The onset of pain with walking is referred to as neurogenic claudication. Neurogenic claudication, as it may resemble symptoms seen in vascular claudication. However, vascular claudication causes pain with exertion and relief with rest, whereas neurogenic claudication is relieved by walking while leaning forward, shopping carts, and an exercise with spine flexed, cycling, and do not incite symptoms. The diagnosis of spinal stenosis can be confirmed on the MRI of the spine. Most patients are treated conservatively with physical therapy and exercise, although some require surgical intervention. Okay, yes, let's take a break. Okay.